Before launching the discussion with my two distinguished guests, I'd like to just give you a brief summary of this paper, of this study. It's a phase 2 single-arm trial, which included 34 adult patients with intermediate risk myelofibrosis who had progression or suboptimal response on stable ruxolitinib dose. So they are rather, I would say, the hard to treat patient. And the choice in the trial, and we'll hear why was this, was to combine actually Navitoclax and Ruxolitinib with a primary endpoint being the spleen volume reduction more than 30 or equal to 35%. And there were some other secondary endpoints which are usually common in this field. Despite the relatively small number of patients, 34, the authors did a great job trying to look into the molecular risk of these patients and do some correlation with response, but also, of course, they did a very nice PK analysis because this is a novel combination. And I thought to show you here actually the primary endpoint, which is about the percentage of the change from baseline in the spleen volume at week 24. And without going into the details, you can appreciate that a significant proportion of these patients actually managed to achieve this spleen volume reduction. And of course, we will discuss and debate whether this is the ideal endpoint to cure these patients. Another important piece of information, which I think is in relation with the pathophysiology of the disease, and of course, is about the bone marrow fibrosis improvement compared to baseline. And again, when it was done in 11 patients, there was, in my opinion, a signal. And actually, the editor of JCO conclusion about the relevance of the study was that you can read it here, very straightforward statement that combining Navitoclax with ongoing Ruxolitinib was manageable in this difficult to treat population and demonstrated encouraging and durable efficacy outcome in this population who have limited treatment options. So that was the summary I wanted to share with our audience, and please do not forget that this is a highly interactive journal club, so you can ask your questions, you can send your comments, and I'll do my best to share them with the audience. So as it is the tradition in this journal club, my first question is always to the non-co-author. So it's going to be for you, Ibrahim, because you are an expert and you are following regularly, almost on a daily basis, the scientific literature about myelofibrosis. So when you've seen this paper and when you read it, what was your reaction? Was it, wow, this is fantastic? Was it, oh, I was disappointed? Or, you know, just share with us your reaction. You know, we are all excited about something when we read it or not.
Thank you, Mohammed. And I would say I listened to the presentation at IACH, the first place, and then I read the paper, you know. Yes, my feeling was, wow. Why? As you know, myelofibrosis is still incurable disease outside allogeneic transplantation, and we have only one drug approved, I would say, family of drugs, JAK inhibitors. And I think I found the idea very attractive with very encouraging results. I would say, and this combination, trying to do something else because we still, I would say, struggling with patient non-responder to JAK inhibitors, for instance, and the second, third generation could not be a good option for those patients. So here, for me, such a study can pave the road to more targeting. We need now to tackle myelofibrosis in the era of targeting therapy.
Wonderful.
Of course, I have other things we can discuss. This.
Of course, we will discuss it, but I'm glad you gave your overall impression about the study. And you nicely mentioned that such a study can pave the way for future studies, and we'll discuss this also later on. But here I'll go to the senior co-author, Dr. Pimaraju. Hi, Naveen, and thank you for joining us. I know it's a busy clinic day. It's noon, and you are in the middle of your clinic. So I'm very grateful you managed to make it today. Can you just explain to our audience the rationale? You woke up one morning and you said, I'm going to give Ruxolitinib and Navitoclax to my myelofibrosis patient. And actually, why Navitoclax? Why not Venetoclax? So can you give us the context and the background of such study, and how was the design was born, actually?
Well, thank you, Professor Moti, and to the IACH, and really just a hats off to you and the IACH team during these extended pandemic and uncertain times to continue to have these type of forums. You're the hardest working person in hematology, and I congratulate you on your recent honors. So thanks for having us here. You asked two important questions here. For this Navitoclax idea, which I have been passionately part of for over a decade, I think I have two answers for you. So one is that there was a very nice paper in 2013, Weibull et al. In the Cell family of journals, so almost 10 years ago, that suggested for the first time, Mohammed, that BCL-XL, not BCL2, which we're used to in AML, MDS, et cetera, with the Venetoclax, for whatever reason, that appears to be overexpressed in myelofibrosis. This came as a surprise to most of us on the clinical side, and that in vitro models showed that inhibition either as a single agent or in combination with JAK inhibitor Rux could overcome JAK resistance. And then the second part of it is the Navitoclax agent has been around. We should note for our viewers that it's not FDA approved for anything yet, but it's been around for a decade, solid tumors, liquid tumors. It's an oral agent. It was actually developed before the Venetoclax. It's been around longer. And so it provided a once daily oral agent that I thought could be clinically feasible to combine for our patients, representing, if you will, a double oral combination, with the appreciation that we'll talk about, I'm sure, that we already knew it causes thrombocytopenia, so we would have to watch the doses of the two. But that's the scientific rationale, that for some reason MF really overexpresses BCL-XL rather than BCL2. And the final point is that some of our clinical studies with the Venetoclax in myelofibrosis have not shown very much clinical activity, particularly as the disease progresses. So new therapies were needed, and we went for this combination.
Thank you very much. That's very clear. And this is a very strong, I would say, scientific rationale. But let me turn to Ibrahim and get his thoughts about the primary endpoint, because obviously your primary endpoint was about the spleen volume reduction, and you have chosen the 35% cutoff. So, I mean, whenever we can, the goal is to cure these patients. And the median age of the patient included in the study was 68, going from 42 and 86. So, Ibrahim, what do you think about the primary endpoint that the co-authors have chosen?
Actually, I would have chosen the same endpoint, I would say, because we need something practical. This is the first study, you cannot rely on the survival, for instance. We can't rely on diminution in myelofibrosis, etc. So, shrinking the spleen is something measurable, and especially they have measured the volume, so it can be something interesting. And I would say, when you start a study, you need a primary endpoint to calculate your sample size, to have something, but you have another, I would say, secondary endpoint, etc., which are important in this paper. So for me, I'm okay. I think you need something to start with. And for myelofibrosis, why not starting with the spleen size or spleen volume?
Excellent. So, Naveen, we have a question from the audience.
Oh, great.
Why choosing the 35%? Why not 40? Why not 30? Or why not 50? Well, and I must confess, I don't know the answer,
Right. Well, it's an important historical answer in our field, and I think these stories are great. So it actually is a bit arbitrary. It comes from the original studies in our field now over a decade. So the Comfort 1 and 2 studies, as both of you know, launched by Serge Verstopsek here and Claire Harrison in Europe. And it is a very interesting story. Essentially, it came down to 35% reduction by imaging, roughly correlated with 50% by regular palpation in the clinic. And it was put forward over a decade ago that 50% or half reduction by palpation, or 35%, would be an important endpoint. Amazingly, the drug Ruxolitinib gets approved with those 2 New England Journal papers, and the rest is history.
So, Ibrahim, any thoughts on this?
Yeah, why 35? You need a number, I would say.
Right.
So they try to be on the safe side. So reproducing what we have in the literature, and they said, why not? Let's go. So for the efficacy, for me, so we can say, yes, you gave this combination to patients, I would say, non-responder to Ruxo. However, I have here just one comment. When I look at the patient's characteristic, I'm not sure you have chosen, the more progressive patients, starting with the age. If you go to the transfusion independency or dependency, you have only 4%. And with the dynamic IPSS, usually we have this idea to split, to break down patient into 2 categories: higher risk and lower risk. Higher risk with the overall survival less than 2 years, I would say, or around 2 years, and higher risk, lower risk, it's something ranging between 6 to 10 years, And we include in higher risk, intermediate 2, and high risk, the dynamic IPSS. But if I look here, 44 of the patient had intermediate 1. That's to say, it's not exactly the definition of higher risk, and we can explain that the overall survival not reached, the median overall survival not reached, because anyway, for the resistance to Ruxolitinib, here also I have this question, because if we look at the real progressive patients with progressive disease, you have 12%, and you have 44% with worsening disease at the clinician, discretion or feeling, and you have 44 lack of adequate. I would say this combination demonstrated a good efficacy in patient with suboptimal response to Ruxo. Why I'm interested in this? I'm a transplanter. And we have just published, the paper for Ruxo before transplantation. We demonstrated that patients responder did really better than those who did not respond before. And the question here, what we need to do, splenectomize those patients before transplantation. We have nothing to do after failure of ruxolitinib. So this combination can be really as a salvage for us, because we can increase the response in at least one patient out of three. I'm talking roughly, so it's a good indication for me, because really before transplantation we look to control the disease. If we can do it with Ruxo, it's okay, we are very happy. But if not, so this was an unmet medical need. So this study can be the first in the way how to deal with those patients.
So, Naveen, you have always the right to answer and explain why you did things. So if I summarize well, what Ibrahim mentioned, and actually this is in line with a few questions we have received and comments. So first criticism, or at least observation, is about the level of risk of these patients. And what I hear from Ibrahim is that not all of them are really the so-called hard to treat or high risk. The second comment he made, and that I can view it as a positive or negative criticism, is about the bridge to transplant. Although in the supplement of your paper, I could see that only 2 patients were able to proceed to transplant. So in another word, you had in hand maybe a good combination as a bridge to transplant, but actually only 2 out of 34 were able to make it. So maybe you can comment and clarify these 2 issues, the hard to treat population, your definition, and why we didn't see more patients proceeding to transplant while you had a relatively good and safe bridge. And according to Ibrahim's consortium, these patients are rather doing well with transplant.
Yeah, absolutely, guys. First of all, outstanding. Really appreciate this discussion. I think for the first point, Ibrahim, you're exactly right. It is interesting that 44%, almost half the patients, are intermediate 1 by a DIP score. That's absolutely right. That's in our table for the patient characteristics. I think 2 points that I would say for that. One is that we had over half the patients were not only high-risk molecular mutations, but also they had multiple high-risk molecular mutations, and all the usual ones that you and I know. So ASXL1, SRSF2, IDH, EZH2. So even though that's a little bit newer age, not really incorporated yet, we know we do have the MIP70. In all truthfulness, we didn't apply that prospectively here, but I think these patients are high risk by other definitions than our clinical IPSS and DIPS. And then obviously all these patients had splenomegaly and symptom burden. The second point, also interestingly, when we look back at the COMFORT studies, I was surprised myself. I think I missed this myself, that a lot of those patients were intermediate 1 risk as well in some of the original JAK inhibitor studies. But again, like our patients, had splenomegaly symptoms. So this is a great point. If you'll allow for my argument, I think people can now be high risk through other pathways, molecular mutation, and these patients surprisingly were enriched for that, maybe accounting for why the Rux alone wasn't working. The second point you guys bring up is very important. Even though it's a small number, 34 patients, only 2 patients, as evidenced in our supplement, as Mohammed noted, were able to successfully bridge to transplant. Those 2 were success stories. It wasn't a particularly older group of patients, so there were some younger patients. I will note that there were a dozen patients who had other things, right? So you did have a couple patients who came off for physician decisions. So those patients, didn't go to transplant on the study. 5 patients, ultimately progressive disease. There were several deaths in the long-term follow-up, 5 patients, some of which were in the setting of infection. These are sick patients, some of them older. Out of the remaining patients, I think some of them will still go to transplant. So in our next update, we'll have to see. But you guys make a good point that I want to say myself. Allogeneic stem cell transplant is still the only curative approach in myelofibrosis. These drugs and drug combinations are nice. We think we're seeing the start of disease modification with this particular Navitoclax program, but you guys are right. For me, cure in MF is whatever I do for the patient, decrease spleen, feel better, whatever it is, but I'm trying to get to an allo transplant in the younger fit patient. I think that we have to say out loud.
So, if I may, I would like to defend Naveen, So, for Muhammad, of course, when you say only two patients underwent transplantation, it's few, but we need to keep in mind it's 34 patients, half of them aged more than 68, and one of inclusion criteria was comorbidity or impossibility or ineligibility to transplant. So for transplantation, we all know not only you look at the age of the patient, you need a good donor, you need to check many things. So for 34, it's 17 patients. It's difficult to judge, to see if really they were fit to transplantation or not, and two of them. But the idea is really to tackle the patient failing ruxolitinib before transplantation. It's something that we need to look at.
Thank you, Ibrahim, and I think this is a fair comment, and I appreciate. Naveen, we have a couple of questions for you from the audience. First question is that you have included, I think, a small number of patients who are resistant to ruxolitinib. So wouldn't it be more interesting actually to use Navitoclax alone or combine it with another drug? That is one question. And the second question we have from the audience is that whether you have seen a difference in terms of response to the Navitoclax Ruxo combination between patients who had the suboptimal response to Ruxo versus those who progressed their disease before.
Yeah, this is a super important point. Here we were guided quite a bit by the science, the preclinical science. To our surprise, in that Weibull paper and some of the other ones in the lab, even if you are failing or suboptimal to the JAK inhibitor, in this case Rux, it is important that the addition of the Navitoclax to that seemingly failing or suboptimal combination then sort of reignited the synergistic benefit. So it is a very novel concept to even me, that adding on the second drug actually bolsters your original drug. So I think that's an important point. I think it'll be interesting for future directions to test the Navitoclax with the other JAK inhibitors, right? We have two available now in the United States, fedratinib and pacritinib. And of course, as you well know, the momelotinib is in a regulatory consideration. So that will be interesting. The second part of this viewer's question is fascinating, right? So, hey, you've got something that looks like it has early encouraging activity. Let's keep following it. What about combining it with other agents? Sure. So as you all know, we are groups together. We're looking at these novel agents, imetelstat, telomerase inhibitor, CD123, bromodomain, PI3, you name it. So I think those concepts will start to come now that this field is emerging. Remember, as Mohammed mentioned at the beginning, this field didn't really exist until 2 or 3 years ago as a clinical field. And then finally, I think we need to be on the watch out now that we're entering into the combination era, like we've seen in AML or multiple myeloma. I think we need to look out for not only toxicities, but novel molecular resistance patterns, right? So JAK2 mutations, CALR mutations, dynamic acquisition of other mutations that may make you resistant to one combo and select another. So those are some of my thoughts there.
Okay, wonderful. I have a question, maybe I'll direct it to Ibrahim. And this is about, based on these results, would you be willing, Ibrahim, to test this combination actually frontline? Instead of waiting until they become non-responders or suboptimal response to ruxolitinib, why not giving the doublet treatment frontline, based on the same criteria, having a big spleen, symptoms? What are your thoughts, Ibrahim?
Okay, thank you for these questions. This is very important. I would say no. Why? because we need to look at the toxicity, because when you give this drug, you give the drug till progression, and you are dealing with the frail patients. So if with Ruxo alone, I would say, alleviate some of them, and I can manage some of them, I don't need to give this combination for everybody, I would say. And my question, because you said the toxicity was manageable, but 88% of patients presented at least one serious adverse event, more than 3 or 4, grade 3 or 4, especially thrombocytopenia.
Right.
Of course, there was no bleeding,
Right.
and neutropenia. So my question is, for patients who developed severe cytopenias, thrombocytopenias, and neutropenias, this is just one episode, or this is a long-lasting thrombocytopenia, neutropenia? Because this is very important for us. When you start treating your patient, if you need to face a few weeks with cytopenias, and then everything will go right, it's very nice, but you cannot, stand the idea to put your patient for several months or years with cytopenias.
So Ibrahim, you're making my life easy, because this question is in line with a couple of questions we have received about the safety profile. And maybe, Naveen, you can highlight to the audience what are the warnings, if any, in terms of safety and practical management if such combinations become available in daily practice.
Well, you both and the viewers are hitting on the right aspects, because you should not let me go off the air without mentioning that. That's right. So as Ibrahim and you noted, there's two actually side effects to bring up. One is the thrombocytopenia, known before. Actually, there's a scientific answer for it. The BCL-XL is actually expressed on these mature platelets. So that's good and bad for us. Bad because it causes thrombocytopenia, but good because, as Ibrahim asked the key question, it's pretty reversible, transient phenomenon. So thank God we saw, and we continue to see, no bleeding, no major hemorrhages due to this phenomenon. The second point is clinical practical. As you guys know, this is the most important thing. You have sort of overlapping potential toxicities with JAK inhibitor and this agent. So we built in prospectively, and we're able to easily follow intra-patient dose escalation and de-escalation. So actually, the drug starts at 50 a day, 50 milligrams PO daily. You can go up to 100, 200, up to 300 and come down based on the platelet count check. I will say, though, that it has to be done weekly for the first several weeks, which can be an inconvenience for the older, frail patient, someone who lives far away. So practically, it will be a concern, to follow, check the platelets. But after a while, as Ibrahim is asking, actually, we saw the platelets normalize in everybody. So that was reassuring. There is a GI signal as well. I've noticed that a lot of our JAK inhibitors, and now these novel non-JAK inhibitors, so you do have to watch out for diarrhea, nausea, vomiting, GI. So you'll see that as the most common non-hematologic toxicity. And then finally, I think these era of combos will be coming somehow or the other in the next 3 to 5 years. You both make such a good point. United States, Europe, across the world, we're in controlled clinical trial settings, right? So we have a monitor, we have people following. So to answer your questions, we have now launched Transform 1 and 2, randomized phase 3 studies, frontline combination versus placebo-based combination, and then second line to answer these questions. The dosing, I think, is a bit simpler. We know about the thrombocytopenia, and it has to be a format that the community practitioner can give. So stay tuned for those results. Global studies, Transform 1 and 2, phase 3 studies to answer these two questions you put forward.
So Naveen, I have one important question to you, because you have alluded to the randomized trials, which obviously will establish whether such combination is the real answer, or the best answer, or the optimal. But our friend Nicola Polverelli from Italy, hi Nicola.
Hi Nicola.
Asked an important question about your expectations in terms of fibrosis regression, because we know that is the key, I would say, issue in this disease. And if you are able to restore, I would say, the bone marrow status, maybe that's going to pave the road to cure or at least long-term outcome. So what was your feeling from the study? Because you tested 11 patients.
Yeah.
So it was like not black, not white.
Right.
I thought it was in the gray zone.
That's right. Yeah, this is one of the surprising serendipitous findings, and I know Professor Ibrahim noted it as well. We were surprised and happy to see that you did have at least 33% of patients had 1 or 2 grade bone marrow fibrosis reduction in this small group in a pretty short period of time. And it's a centralized study, so we know that we have, very reliable results in that regard. I have to say, I'm happy and impressed to see that. You both are correct. We know that this is the holy grail of myelofibrosis, which is disease modification. Can we finally, for the first time, show that a treatment or combination does all of the following? Reduces bone marrow fibrosis, reduces variant allele fraction, so the JAK2 or CALR mutation burden, reduces spleen, improves symptoms, and then ultimately improves overall survival. And while you're doing it, decrease cytokines. Early on still, but as you saw in our paper, we did that with this combination. The second point and final point would be, that's why I'm personally willing to put up with some GI side effects for our patients, some thrombocytopenia, if we can get to what Professor Modi just said, which is some transient short-term for a potential long-term benefit of disease modification. We three know we have to have longer follow-up, more presentations. Let's see how the phase 3 data goes. But I'm personally very excited and impressed by what I'm seeing so far. Let's keep managing the toxicities. Let's get a longer follow-up.
Superb. So my last question to both of you, and I'll start with you, Ibrahim, is that assuming you have whatever research grant needed, so money is not an issue, you have all the drugs available, what would be your ideal treatment regimen or protocol you would like to build to cure a substantial proportion of myelofibrosis patients? And you can prepare yourself, Naveen, to the same question.
So this is difficult because we have, I would say, 2 kinds of patients, lower risk and higher risk. So I would say I will put everything I have for patients with higher risk, but I will manage patients with lower risk, without toxicity, etc. So if we look at the higher risk patients, you have 2 kinds of patients eligible to transplant, and you have a good donor. I'm talking for the time being. We are in 2022. I'm not talking about 2030 or whatever. So I need to prepare them for transplantation. So I need really to control the disease. I would imagine something strong, short, and something can really play a role in the mechanism of the disease before transplantation, and then establish a good hematopoiesis after this. For the patients who are ineligible for transplantation, so what we need really to give them something well tolerated, effective, but in long term, to really control the disease, long-term control of the disease. So I would say this is my...
So one quick question before moving to Naveen, because I noticed I didn't take this question yet. It has been posted some time ago. Would you be willing, Ibrahim, to use Navitoclax as a maintenance treatment after transplant? Or
I'm thinking...
Okay.
Yeah, I'm thinking of this. Why? Because for the key point for me, it's really something regarding myelofibrosis. Because it's
Right.
a very difficult question, because you need a biopsy, bone marrow biopsy, and it's very difficult to investigate, to understand. But we need something, of course, because even after allogeneic transplantation, we still see myelofibrosis 1 year after transplantation, etc. So Navitoclax can be a good idea really to get rid of this myelofibrosis and to accelerate the establishment of healthy hematopoiesis.
Excellent. So Naveen, unlimited resources, any kind of drugs, transplant, no transplant, what would be your ideal protocol? I know you've launched the Transform 1 and Transform 2, but what would be your ideal future protocol to cure more myelofibrosis patients?
This is the exact question we need to be thinking about in our field, and I'm so happy you've given us the chance to talk about this. I largely agree with Ibrahim's nice comments. I like the way he divided it, transplant and non-transplant. I'll add 2 buckets to that, Ibrahim, see what you think. So in addition to your nice formulation, one is identification, Mohammed, of key molecular subsets. You and I have seen this, and we've been a part of it in AML, multiple myeloma that you have led, ALL lymphomas, all these other agents. But myelofibrosis, we've lagged a bit behind. So I think the incorporation of the molecular mutations into the scoring system is okay, but let's see if we can develop targeted therapies and combos. So IDH comes to mind that already has this. Not many of our patients have FLT3, but TP53, et cetera. So can we bring those successful programs, IDH inhibitors, magrolimab, whatever, for IDH TP53? So I'd like to see that. That may account for anywhere from 10 to 50% of our patients, particularly as they progress to accelerated blast phase. And then 2 is the elimination of stem cell transplant, or at least in these patients who are older, unfit, who are never going to go. I'd like to see these combinations go forward. So in addition to the BCL-XL Navitoclax, also in phase 3 ongoing frontline is bromodomain with Ruxolitinib, so BET inhibitor, PI3 kinase inhibitor. So I personally, although I'm biased as we've established here, I think the combinations, JAK inhibitor plus a novel agent, probably even in frontline for the high-risk patient, in chronic phase still, not just accelerated blast phase, with the intention of improving overall survival. Guys, the overall survival in second-line MF after JAK inhibitor is only something like 14 to 25 months, right? It's only like a year and a half. So if you can give someone overall survival for 3, 5, 7, 8 years without a transplant, unfortunately, that is a big victory for our patients. Obviously, we want to go for long-term cure. So I think those are the 2 things I would say: identification, molecular subsets, combinations upfront that minimize toxicity and improve overall survival without a transplant.
Well, that's really a very nice conclusion. Again, huge congratulations, Naveen, for this beautiful JCO paper. And I think everybody in the community, in the hematology community, is very grateful to your work, because you are really focused on these very hard to treat diseases. Of course, we know the story, the revolution you paved the way for in BPDCN, and now in myelofibrosis. So I think we are all grateful. We know that these are not very easy studies. I'm very grateful to Ibrahim for joining us also tonight, and I would say play the game of this pro and con discussion. So this is really
just
of course, please do.
Yeah, please. So Naveen, at the Chronic Malignancies Working Party of EBMT, we have our workshop. We are dealing with how to manage splenomegaly before transplantation, So your work will be there, absolutely.
Wonderful. Thank you, Ibrahim. Right on.
See, Naveen, you managed to get an invitation.
Thanks to you.
To the IACH Journal Club. I'm a bit jealous because he didn't invite me, actually. We need to close it now. We have reached the end of this lovely journal club. So thank you both for contributing.
Thank you very much.
This is really very, very high level and top cutting edge scientific discussion. So thank you very much. I'd like to thank our audience for being loyal to the IACH Journal Club. Of course, you see the topics are very heterogeneous from one journal club to another, but that is the concept of it. And please, if you see an interesting and important paper that you would like to see being discussed during the IACH Journal Club, just drop me an email. Just drop an email to Professor Nagler or to any other member of the steering committee of the IACH, and we will discuss it and figure out how we will include it in because of course the scientific literature is so huge, and we have only 2 broadcasts per month, and these are, by the way, live broadcasts, but they're all recorded and you can watch them on the website of the Academy, open access, clinical-hematology.org. For the time being, I wish you all a good night, a good day, a good afternoon, a good morning, wherever you are. Please stay safe and keep well. Take care.
Thank you, Mohammed. Thank you very much. And
Thank you,
bye-bye.
Mohammed. Thank you,
Bye.
IACH team.
Bye.